What is scarier than what I'm wearing right now for Halloween? Maybe what's been happening in New York regarding COVID-19. And urologists in that area, especially Dr. Michael Levine in his practice, has come up with some innovative ways to keep patients out of the hospital so that they can take care of them in a safer environment. In today's video, we are going to talk about how he is and his group are putting up ureteral stents in the office with ultrasound guidance. I am extremely honored and super happy that he is so late at night coming on here to share his knowledge and wisdom with us. So thank you so much, Dr. Levine.
My pleasure, John. Thanks for having me.
So let's talk about the how, why, and who. I assume it's because you want to keep the patients out of the hospital in New York because of what's going on. But maybe I'm assuming wrongly. Tell me why you guys decided to start putting up stents in the office.
You're absolutely right. Late March, early April, things really started to pop up in New York, as you know, and we didn't really have a plan in place. The backstory is that I'm part of a very big group with a lot of resources, and we put together a COVID-19 task force very quickly. We were very proactive, and we actually took control of the company through the task force because it really became the main issue on our plate. And we had a lot of protocols in place, geared up on the PPE. We managed our employees. We cut back our hours. And then patients, like they always do, they started showing up with colic. And, you run into these things and you say, well, what do I do with this patient? Typically, you would say, oh, go to the ER, shot a Toradol, buy them some time. If the Toradol wears off and they're still having colic, we meet them in the hospital and we put up a stent, or we get the stone out if they're not infected. The problem is that the hospitals were overrun. The ERs were basically turned into COVID wards. The fear spread very rapidly, as fast as a virus, and nobody, including the doctors, unless they had to, did not want to go into the hospital. So a patient came in with bad colic. He was a stable guy, 70 years old. He really had no comorbidities. He was not septic. He wasn't tachycardic. He really had no signs of anything bad looming that we see in these patients. And I said to my partner, I said, why don't we just put up the stent in the office? I had done a few in residency, working through a VA hospital. I felt comfortable at least giving it a shot. We have an ambi center, so I ran to the ambi center. I grabbed a couple of wires. I grabbed a couple of stents. We told the patient what we were doing and that we don't know if it's going to work. You may have to go to the hospital. The full consent with the possibility of sepsis and so on. Gave him a shot of amikacin, waited about 30 minutes, and we did a sonogram. We saw the hydronephrosis. Let me back up in first that he did come with a CAT scan. So we knew that it was a distal small stone. And we scoped him. We passed a wire through the scope, which is very, very easy to do. I will tell you that you should not use a sensor wire. You should use a green wire because it's a little bit stiffer at the end. So if there's a prostate to angle against, you can torque the wire up the ureter. And as the wire gets into the kidney, you could see it on a good sonogram. If you have a good image, you can actually see the shadow, the dropout of the signal. And then over the wire, you pass the stent. Unlike a flexible scope, is longer, so you can't use a traditional pusher. What you need to do is use a ureteral catheter as the pusher. So we use that. We push the stent over the wire. Watching like you typically pass the stent. We thought it was in the kidney. Pulled the wire, it coiled in the bladder, and sent the patient for immediate KUB. Came back, you saw the stone, you saw the stent, patient was doing well, and all was good. And we said, wow, we really have something here. This is how we should be managing colic going forward, at least in the pandemic. And we did 15 cases. In one case, we couldn't get the stent up. Sent the patient for a KUB. We saw the stent was coiled under the stone. The patient was fine, and we treated him traditionally, brought him to the hospital and put the stent up. But 14 out of 15 is pretty good when we didn't even know if it was going to work. So I think what we're facing now is, could this be a change in the standard of care? Why do we need to bring patients to the OR, send them to the ER, incur the expense of the ER visit, the unnecessary labs, if somebody who's stable, and start putting these stents up in the office?
That sounds like a really, really neat idea, but you covered a lot of information there. So if I can kind of go back. So we do have a lot of people watching live. So I encourage you, if you have any questions, go ahead and ask in the comments, and I will relay the questions to Dr. Levine. So first of all, patient selection.
Okay.
You are seeing these patients as outpatients. They came in with a CT with colic, and then you kind of have an idea of the type of stone and how big they were. Is that correct among your 15 patients?
Correct. Not everyone had a KUB. They could have been uric acid stones. We weren't that concerned about that. We were more concerned about, did we think that we could stent the patients? So when you talk about selection criteria, we were very careful, because you know how these cases can go. Patients can become septic very quickly and crash. And here we are in our office with, you figure hospitals are good until they're actually seen and treated. It could be a good hour. So we decided we're not doing anyone who's tachycardic. We're not doing anyone who is febrile. We're not doing anyone who has significant comorbidities. And that's something we decided where type 1 diabetes, that's brittle. We were doing type 2s. We thought that was fine. Somebody who we thought we wouldn't be able to get the stent in. There was one person who came in who had a known very, very large prostate. We just didn't want to do him. We figured we would fail. Again, no tachycardia, no hypotension, no fever, no signs. And when you do this for a while, you can look at a patient. If you have a couple of data points, the patient's stable, they're not.
Sure. And how many men and women among the 15 did you have?
It was 11 men and 4 women.
Okay.
Yeah.
What were the stone sizes in the ureters among the 15 patients?
Up to 1.4 centimeter.
Wow.
Most of them were small. The bigger stones were in the proximal ureter, as you would expect. And it didn't really make a difference. What you'll see in the paper that we finally put out, the stone size and the stone location did not correlate to the ability to pass the stent, because we got them up. So if you're using a small, a guide wire, and you keep the cystoscope very close to the orifice, it won't buckle when you're passing it in the bladder. And the wires went up. I mean, it's rare that you don't get a wire up, right? Even in the OR, there are cases where the stones are impacted and you can't. And we decided that if we couldn't get the wire up in a reasonable amount of time, we were just going to abort.
And you didn't, among the 15 patients, you didn't have to abort. You were able to at least get something up. Most of them, you were able to get a wire up. One had a distal coil under the stone.
Right.
Okay.
Yeah.
So
correct.
Patient selection is important, obviously. Stone size, you didn't really care. All of the stones are in the ureter, and the patients, you really have to be careful on whom you perform this procedure. Now, you said you went to Ambi Center. You mean a surgery center? Is that correct?
No, this was done in my office.
No. You went to the surgery center to grab wire and stents.
Correct.
Okay,
correct.
So your group has or owns the surgery center.
That is correct.
Okay, so I'm trying to think in terms of small practices that may want to do this, or private practices. Where would they get the stent? Where would they get the wire? And also, is it financially a good thing to do? Because sometimes, the disposables can be really expensive.
Absolutely. Well, to be quite honest with you, and I'll get into the details of it, at that time, I knew I can get the wires. I knew I can get the stents because they were available. I really wasn't even concerned about the reimbursement. I just wanted to stay out of the hospital. And the patient wanted to stay out of the hospital. And I figured, how much could the wire, how much could the stent really cost? I didn't really even know. I had an idea, but it was more important to me at the time to stay out of the hospital.
Yes.
As it turns out, though, a green wire, a PTFE 0.038 Teflon coated guide wire costs $8. Okay. A 24 centimeter 6 French double J stent, or any size for that matter, from Bard costs about $49 to $52, depending upon your pricing. Now we may have some better pricing because of the ASC, but if you had to buy the street rate because you bought a dozen stents, under $100 for a stent, guaranteed, for sure. At least you shouldn't be paying more than that. If they try to pay you, if Bard tells you it's $500, call Boston Scientific. You'll get a reasonable price.
Or
because
Cook.
It's not that,
you know what? There's so many players right now. You can call
Um,
Boston Scientific. You can call Cook. You can call the Dornier.
Yeah, there's a lot of manufacturers, and I'm not plugging any one of them. You need a stent.
Yes.
Okay, in this kind of a situation, any one I think will do. And
you are recommending just a straight old PTFE and not the fancy sensor wire.
I think it's better without the sensor wire in this particular case, because you want that rigidity. Even though it's floppy, you want that extra rigidity as opposed to the glide tip of a sensor.
You're talking about the initial insertion into the ureteral orifice.
It's easier with the green tip wire.
Interesting.
Green wire.
Interesting.
Yeah.
Okay. So patient selection, we went over. You're doing this in the office. You're getting this wired and stent. We can figure out how to get that. And let's talk about, you're doing it in like a procedure room in your office.
Yeah.
Using a flexible cystourethroskop.
Correct.
Okay. You visualize the ureter opening. You put the wire up, and then who is telling you that the wire is all the way up into the kidney? And how is that?
Okay, so I would do it with one of my partners. Now, remember, during COVID, we weren't that busy.
Of course.
We were basically open for only emergencies, right? Retention, hematuria, fevers, UTIs, stones. So we would see 10 to 15 patients a day, and we were there, we were around. And we had a couple of medical assistants that we brought back, and they weren't part of the workshare program. So you really need, just to start, I would say 2 urologists, just 2 people who are very familiar with the technique and ultrasonography if they do it, and a medical assistant to assist you and, maybe hold the back of the wire, things like that.
That is wonderful. Now, let's get into the details. Now you have the wire up. One end is sticking out of the flexible cystourethroskop, and the other urologist has confirmed, okay, I see this hypoechoic area and wire into the collecting system. How is the stent placed over the wire into the kidney?
Okay, so the wire is passed through the nipple on the flexible scope, which also has an irrigation port. You pass the stent as far as you can, and it's basically still in the scope, right? Because it's about 24 centimeters. The scope is probably 40 centimeters. Once the wire disappears into the nipple of the scope, you then take a ureteral catheter, pass that over the wire, and push the scope, use it as a pusher, push the wire into the ureter undivision.
So like a 5 French ureteral catheter, you're using that as the pusher.
Correct.
You put that over the wire, and then, so you need 3 things. You need the stent, you need the wire, and you need a 5 French ureteral catheter.
Correct. Now, there is a little nuance, because you will run out of wire in the length of a ureteral catheter once you start advancing it. So you need to cut about 4 centimeters of the ureteral catheter off to make a very long pusher, but not quite as long as a ureteral catheter.
Nice. So that's a key point right there. Okay, let me ask you a question. What have you billed for, and what has reimbursement has been like? Okay. Yeah, more of a billing question.
Right. So I haven't looked at all of them, to be quite honest, but I did look at a couple, and I could tell you that passage of a stent has a very, very high site of service differential. And I guess most of the people on the group are familiar with what that is. Whereas if you do it in the hospital, you get paid X. If you do it in your office, you may get paid 4X.
Okay, I'm going to put up on the screen the payment for 52332, which is the stent placement. Nationally, if you were to do it as a participating provider for a Medicare patient in a non-facility, which will be in the office, nationally is $467, and in the office in New York City will be $564.06. And if you were to do it in the participating facility, like a hospital, you would be paid $161. So yes, that is correct. What about anything else besides the stent placement code? Are you guys billing for anything else besides that?
We're billing for the ultrasound.
Okay.
Most carriers will let you do it. Some carriers will not let you do sonogram in the office, but that was irrelevant. We billed to the injection shot for the amikacin, or whatever antibiotic we were able to give them. Um, I have to check. Honestly, I'm not sure if we were billing for the visit as well. Probably billed an office visit too, because it was all, and there was a modifier for the procedure.
Yes.
So, it's a pretty robust bundle of codes when you consider what you would get to spend who knows how long in the hospital at God knows what hour when they would finally give you time to do it.
Yeah.
Plus, aside from all that, we stayed out of the hospital. The patient's thrilled because the stents went up and they went home. And it's pretty amazing because we put up stents under anesthesia typically. And although you see the expression of, although you see the expression of ureter come down, you see the efflux alongside the wire, you're past the stone. You never really know how the patient feels when the wire goes up. I will tell you that putting a wire above an obstructing stone is like putting in a Foley on somebody who's in retention. They know when that wire is above the stone. Wow. You see the urine come down and they immediately feel better. And it was really kind of a paradigm shift because we never really experienced that because they're always under anesthesia.
Wow, that's phenomenal. I mean, that experience that you've gone through, and then the little tip about cutting off about 4 centimeters of the 5 French ureteral catheter is key. So when it comes to billing, let me come back to that, because it is, if we all decide, or a lot of us decide to adopt this in the office, we would need to know all the details. And it's the 52332, and also probably a limited retroperitoneal ultrasound. Is that what you guys bill for? Okay, so that would be about $76775, and in New York City, that would be about $70.92 for Medicare, and nationally is about $60.
Yep.
So you are correct. If you saw the patient, that will be an E&M visit, and then you decide to do all these procedures. It will be, these are 0-day global procedures, and I think the ultrasound is a 7 code. So I don't think you take a 50% reduction in that code. I would have to put it through the coding, the bundling matrix on the AUAcodingtoday.com's calculator to determine that for sure. And also injection of the antibiotic is potentially a billable situation, depending on payer, of course.
Right. There also may be a stone manipulation code that we use as well, because our biller is used to billing these stent placements when there are stones in place. I don't know if she used the stone manipulation. I don't think she did, because we really had no confirmation, like fluoroscopy, where you would know the stone was manipulated. It's more of a hospital code when you have more confirmation of that. It's a possibility. I don't think we used it.
Okay. So basically, cysto, stent placement, limited retroperitoneal ultrasound, plus or minus injection of antibiotic. Right. That's phenomenal. I mean, I don't think you can bill for that, for the antibiotic in Medicare, but I think private payers, obviously, that is always a possibility.
Yeah, it's nominal. It's very inexpensive, but again, the coverage we thought was important. And we sent them home on antibiotics. We followed them closely. We called them. And of course, following them like anyone who had a potential for a septic episode, we kept tabs on them. Plus, we were doing something new, so we were concerned. But there was no readmissions to the hospital. There was no febrile incidents afterwards. And going back in to do those cases later, no stents were encrusted. There was really no sequela putting the stent in, other than the typical stent urgency frequency dysuria, which goes along with putting in a stent.
Man, that's so awesome. You're able to serve the patient, keep them out of the hospital in New York that's already overwhelmed at that time, and then take care of them safely afterwards. What is the time period between stent placement in the office and then subsequent treatment of the stone?
I think the first patient waited for about 3 months because there was no rush to do anything. In fact, I have a couple of patients who are still out there who have stents in for a few months. They just don't want to go to the hospital. I'm going to get a little bit concerned about incrustation at some point, but having gone back after 3 months, I'm less concerned about it. It's like any kind of stent protocol. You keep a list, you make sure who's out there. But now the numbers are coming back up in New York. So it may be a little bit more of a challenge to get these people in, but I think it's something we're willing to live with, and so are the patients.
Yeah. Well, once again, those of you who are watching live, there are quite a few of you. If you guys have any questions, concerns, please leave them in the comments, and I will run the questions over to Michael, and we'll try to get them answered during this live stream. So, are you guys thinking, Michael? Are you guys thinking about doing this from here on out, or just during the pandemic? Because I think this is something potentially viable, not just during the pandemic, but for the well-selected patient, for everybody in the
Yeah.
U.S.
I think we're in a paradigm shift. I mean, there's really no reason because we haven't had any complications. It really could be done on the fly of your office hours. If you know you have somebody coming in, you just have the room set up and you find some time. You tell them to come in, when you have a little bit of a window, say, listen, we're breaking for lunch at 1 o'clock. Why don't you come in then? Or if you're in severe pain, just come and we'll run a little bit behind taking care of you. You get really fast. Your medical assistant gets really good about knowing what to pull for the case. The site of service really makes it a great value play, and you're taking care of the patient better, faster, cheaper.
Yeah.
It hits all the marks in what we need to do as physicians, right?
Yeah.
Our time is so valuable, right? You're doing it better because you're not subjecting them to the anesthesia they may not need. You're not running them into an ER where there may be exposure to COVID, and you're doing it less expensively. So it really checks all the boxes.
Yeah, it's truly a win-win-win. The only caveat is you would need a second urologist. So if you're in a solo practice like me, that would be a little bit more difficult. Unless, as in preparation for this interview, I was thinking one way to get around that may be to have a fixed articulating arm that I can place over the patient's kidney, and then have the ultrasound machine already stationed there. Patient will stay still, and then I can look at the image as I'm putting up the wire.
Yeah, I'll tell you, I put them up myself with my medical assistant at this point because I feel pretty comfortable. And I am sure in battlefield conditions, I could do it myself if I had to. I wouldn't want to. But you know how it is. You do more, you feel better, you find ways to get it done. But I would say that the first one you do, you should have somebody at least skilled at sonography. And if you have someone who could hold the wire, it's probably good enough. We did it together because we were both there and we had the time.
Well, that's wow, that's great. I can't wait to see the paper when it comes out. And I think we can all very quickly do a back of the napkin calculation on the finances to make sure that you're not upside down when you do this procedure.
Yeah, I'm pretty sure it'll work out.
All right. Anything else that you would like to add?
No, I would just say if you feel comfortable, give it a try. You're probably not going to hurt anyone as long as you know your limitations. And I think overall, it's really, really, it's the right thing to do if you can do it.
Wow, phenomenal. Dr. Levine, thank you so much for coming on here and spending time on a Friday evening.
All right, my pleasure, John. Thanks for having me, and you have a great, great, great show going. Keep it up.
Thank you so much. All right, for those of you with any questions or comments, please leave them below, and I'm sure Dr. Levine and I will try to get back to you as best as we can. Other than that, have a great Halloween and good night.